In this next part, we're going to talk about justice in some real-world examples. So, for a number of years, I worked in a community-based hospice. For those of you who aren't familiar, hospice is a model of palliative care in the United States for people with a 6-month prognosis. So 2 physicians have to attest that a patient they wouldn't be surprised if this patient died within the next 6 months. And so for people who qualify, the Medicare hospice benefit pays for 80% of the people receiving hospice services in the United States. And the Medicare hospice benefit replaces hospitalization. So patients who elect Medicare hospice benefit have to say, I will forego curative treatment. This is most easily conceptualized in the context of cancer. So a cancer patient who has a 6-month prognosis says, I am not interested in pursuing curative-oriented treatment anymore. I am going to focus on symptom management, distress management. And those people, Medicare pays a hospice organization a daily per patient rate. In return, the hospice provides 24/7 access to care, home visits wherever the patient calls home by an interdisciplinary team, which means nurses, social workers, chaplains, sometimes physicians, often a home health aide. They have to provide all medications that are relevant to the terminal prognosis, as well as all durable medical equipment. And you can think of this as for a routine patient, the hospice gets, say, $150 a day. It obviously gets more complicated, but let's go with that. Hospice medical directors have to help decide who to admit to the hospice. A hospice medical director has a number of responsibilities in these circumstances. First of all, the patient and family in front of them is first and foremost. How do you address their needs? How do you assure that their goals and values and preferences are in alignment with the hospice philosophy and that you are going to be able to meet those needs? Second, you have a responsibility to the CMS regulations. There are detailed requirements about what makes a person eligible and how long they're eligible to be on hospice. The third piece is to your organization. If you take every patient that comes in the door, regardless of their acuity, regardless of their cost, you run the risk that the organization would be bankrupt and you can't take care of any additional patients next year or the year after. How do you make this decision fair? So I watched hospice medical directors struggle with this in an organization that had 7 different locations across a few states. How do you make sure that the decision one satellite center is making is comparable to the decisions being made in a different one? Why should the decision of who gets access be different between one organization and another? That's a fundamental question about justice. And hospice medical directors can't be in this alone. It's very difficult to be the solo decision maker. How do you create a system that supports them, that gives them that fair process, that procedural justice, that makes them feel confident in the decisions they make? So why do I bring up hospice? Hospice is very different for the fee-for-service traditional method by which physicians and other healthcare providers get paid for their services. In fee-for-service, since you get paid every time you do something, an exam, a test, that incentivizes physicians and other providers to just keep doing services because then you make more money. Hospice, on the other hand, gets a single fee for each patient for every day. And so it is up to the hospice to decide what bundle of treatments, of care, does each patient need, does each family need based on their goals and preferences, values, their medical needs, their existential needs. They get to decide. And so the goal of that is that hospices will use their resources more wisely, that they might not make quite as much money as they would under a fee-for-service mechanism, but that they will give their patients better value care, higher value care. So that brings us to value-based care, which is essentially a new reimbursement method that is in this same line of thinking, that instead of eternally using the fee-for-service payment method, which just keeps raising the cost of healthcare, that instead we find ways to incentivize, yes, care that costs less, but that allows us to use our resources in more fair and appropriate ways. So value-based care aligns with the triple aim of not only improving the health or the well-being of the patient in front of you, but also the health of populations and the overall costs, reducing those so that we can do other things with that money, like pay for school lunch. Value-based care sometimes just gets thought of as being about reducing costs. But again, I want to stress that in a system where you have limited resources, money that you spend on healthcare is money that you can't spend in other ways to improve other elements of well-being. So I hope those in-depth examples helped you think about how your role as a physician in society is really impacted by your ability to wrestle with questions of justice.